Okay, hi everyone. Welcome back today. We'll get started now. I got a comment on the evaluation yesterday that some people couldn't hear, so I'm just gonna make sure if can you hear me right now? Okay, and in the back too. Okay, thanks. Let me know if you can't hear. You can give a wave, and Howard's at the back to let me know if it's hard to hear. So yeah, thanks for that feedback. So we'll be talking about the consequences of obesity today. So we're going to talk a bit about BMI or body mass index, which you may have heard of. It is one of the most common tools for the assessment of healthy body weights. You've probably come across it. It's quite common. And this figure shows that there is an increased risk to health with both increased and decreased BMI. So the middle of the curve represents the BMI range between 18.5 to 24.9, and that's classified as the normal weight range. Although normal, there are some other there's more to it than just normal, but there's some more nuance to that. But this is how it's categorized. And then in the scientific literature, the terms overweight and obese refer to specific ranges of BMI, as you can see here. And it is important that you know these numbers. And then there's also the BMI ranges that define underweight, normal, overweight, and obese. So although it is overall well accepted that obesity is a health hazard and a risk factor for cardiovascular disease and type 2 diabetes, there is some heterogeneity among equally obese individuals. So some obese patients have no cardiovascular disease risk factors, whereas some people with type 2 diabetes have clinical signs of coronary heart disease and are characterized by insulin resistance and dyslipidemia and a number of other risk factors. So while we do recognize that obesity or the BMI range of being considered obese, it can be harmful to one's health, there's some questioning around why this condition is so heterogeneous in terms of its clinical manifestations. So one of the reasons why obesity has to be redefined is because it has some different faces. So the evidence published over the last 25 years has established that the subgroup of overweight or obese patients with an excess of abdominal fat or visceral adipose tissue has a higher risk of developing type 2 diabetes and cardiovascular disease. So there are a number of epidemiological studies over the past few decades that have investigated the relationship between body weight and mortality, coronary heart disease, and diabetes. And you can see here in the Nurses' Health Study the association between BMI as a crude marker of total adiposity and mortality from all causes, cardiovascular disease risk, and type 2 diabetes. So is BMI a perfect indicator of obesity? Why or why not? Yeah? Yeah, that's right. So actually, BMI doesn't, you can't tell the distribution or the type of tissue. So there are some limitations with using BMI as an indicator for someone's health, and other risk factors for chronic conditions. Yeah. Yeah, that's right. So that's the fat around the organs. Yeah, that's exactly right. So it also doesn't take into account the distribution of the fat, and where the fat is, can also affect someone's risk of cardiovascular disease and type 2 diabetes. Yeah? Yeah, that's also exactly right. So for again, for someone with a higher muscle mass, it doesn't take into account for that, and someone who has more muscle mass and has a higher BMI may, if we only relied on BMI to determine someone's health, then it may falsely tell us that someone is at higher risk for health issues when really, in fact, that body mass is related to muscle. And so in practice, actually, we do look when we talk to patients, we ask for their weight and their height so that we can calculate their BMI. But there's so many other things that we will consider to help us to determine what someone's risk is, how healthy they are, like their diet, their past medical history, their blood work. So we'll be talking about cholesterol today, and how that's impacted by obesity. But that's also something we will consider is the blood work. We look at the cholesterol results and blood sugars as well. So great answers, everyone, and really good discussion around some of the limitations of BMI. So this notion around the limitations of BMI, and the distribution of body fat is supported by by the findings of the Nurses' Health Study. So in this study, women were stratified into tertiles of BMI and tertiles of waist circumference, which would be a proxy for assessing visceral fat. So irrespective of their BMI tertile, women in the highest waist circumference tertile had an increased risk of coronary heart disease over the 8-year follow-up. And the worst case scenario in the Nurses' Health Study was to have both high BMI and high waist circumference values, as you can see in this graph. And these results essentially provide additional evidence that both BMI and waist circumference are important to assess in clinical practice. And when I worked in the Healthy Heart, so the cardiac rehab program in the hospital, we would again look at BMI, but we would also measure people's waist circumference. So this is something that we do in practice as well. And this just shows you how the cutoffs for the waist circumferences, there are some differences among different ethnic groups. So something to keep in mind. So, obesity increases the risk for type 2 diabetes, cardiovascular disease, and cancer. So, we'll talk about that now. So, this figure illustrates the development of type 2 diabetes. And it's important to keep in mind some two characteristics that are required in the development of type 2 diabetes. So one is insulin resistance, and the other is reduced pancreatic function. So initially, when blood glucose starts to rise, the pancreas responds by secreting more insulin, and this allows blood glucose to normalize. And then this increase in insulin levels in the blood is called hyperinsulinemia. And gradually, the pancreatic function declines, and insulin secretion cannot fully normalize blood glucose levels. So blood glucose levels begin to rise, and this is called prediabetes. And at this point, it is possible with lifestyle changes such as diet changes and weight loss to normalize blood glucose levels. And so we often get questions from patients around how to manage their blood glucose levels when they find out they have prediabetes. So it is possible for people to essentially reverse their prediabetes once they have it through these lifestyle changes. If the lifestyle changes aren't made, eventually the pancreatic function declines to a point where blood glucose levels rise even higher and reach a level that is considered type 2 diabetes. And then at this stage, while lifestyle changes are still beneficial, diabetes medications may or may not be required to manage the disease. So this figure is from an earlier module, and it shows that glucose metabolism and lipid metabolism are integrated through the action of insulin. I won't explain this figure in detail, just to highlight some of the effects of insulin that are important in our discussion today. So in the postprandial state, when insulin levels are high, the hormone promotes the uptake of fat by adipose tissue, and then reduces the uptake of fat by muscle tissue. And this is to promote the use of glucose as a source of fuel by the muscle immediately after a meal. Similarly, when insulin levels are low, there is increased release of free fatty acids from adipose tissue, as insulin no longer suppresses hormone-sensitive lipase, and there's a greater uptake of free fatty acids by the muscle. In the fasting state between meals, this release of free fatty acids reduce the need for the muscle to use glucose, and then more glucose can be diverted into the bloodstream and then used by the brain, which glucose is the primary fuel. And then unlike muscle, the brain cannot use fatty acids for energy, which is why glucose is prioritized or diverted to the brain for fuel. So in terms of the connection between obesity and type 2 diabetes, so although insulin regulates free fatty acid release, there is always a baseline level of free fatty acid release from the adipose tissue. And this is to ensure that the body always has a constant source of energy. So at baseline levels, the free fatty acids are released, and it's proportional to the amount of adipose tissue present in the body. And the adipose tissues increase with the expansion of the size of the adipocytes, or the cells of the adipose tissue. And individuals that have high levels of adiposity, meaning that they have a lot of adipose tissue, release more free fatty acids than lean individuals. So these higher baseline levels of free fatty acids change lipid and glucose metabolism in a way that can increase the risk of diseases like diabetes, cardiovascular disease, and cancer. So one of the changes that occur with expanding adiposity is also increased inflammation. So when there are large amounts of adipose tissue, they become starved or of oxygen or develop hypoxia, and this hypoxia results in cell death. So the dead cells are interpreted as foreign bodies by the immune system, and the immune cells are recruited to the adipose tissue where they secrete inflammatory proteins, which act both within the adipose tissue but also affect the rest of the body. So this flowchart illustrates the relationship between obesity and the development of type 2 diabetes. And so as one gains weight, the size of the fat cells or the adipose tissues increase. And this increase in the size of adipose tissue cells change the body's metabolism in two ways. So one is the release from the adipose tissue of high levels of free fatty acids. These free fatty acids enter the blood and reach the liver and the muscle, where some will be used in beta oxidation as a source of energy, and others will be converted into triglycerides and will be stored in both the liver and the muscle. If there is an overload of free fatty acids, as can occur in obesity, the fatty acids will be diverted into the metabolic pathways that are normally not active in the liver and the muscle, and it'll produce these unhealthy byproducts. And this process is called lipotoxicity, and the products that result contribute to the development of insulin resistance in the liver, the muscle, and adipose tissue. So the free fatty acids also enter the pancreas, where these lipotoxic byproducts are also produced, and it contributes to beta cell failure, resulting in the breakdown in the function of the pancreas. And another consequence of obesity is an increase in inflammation, and it happens initially in the adipose tissue and throughout the body, because the adipose tissue secretes compounds that induce inflammation. And then in the liver, muscle, and adipose, this results in insulin resistance. So from this flowchart, you can see that obesity through two different paths contribute to the development of insulin resistance and diminishes the function of the pancreas, which leads to the development of type 2 diabetes. So obesity is also a risk factor of cardiovascular disease. It leads to, again, increased free fatty acid release into the blood, and an increased uptake of these free fatty acids by the liver, and this in turn results in increased secretion by the liver of the very low density lipoproteins, or the VLDL. So this figure shows normal lipoprotein metabolism, and the VLDL is released by the liver and enters the bloodstream to deliver fatty acids to the tissue. At the same time that this happens, some cholesterol is released and is taken up by the high density lipoprotein, or the HDL, to be returned to the liver. As the triglycerides are depleted from the VLDL particle, it's converted first to the intermediate density particle, which is further depleted of triglycerides, becoming a low density lipoprotein, or the LDL. So then the LDL is taken up by the liver and metabolized. So this is what happens when we have abnormal lipid metabolism. When VLDL levels are high, there are the usual lipid transfers that we saw in the previous slides and here in steps 1, 2, and 3. But there also are some atypical transfers. So the cholesterol from HDL, for example, instead of being taken up by the liver, is transferred to the very low density lipoprotein particles, or the VLDL. And this occurs because there are a lot of these particles, or a lot of the triglyceride-rich VLDL circulating in the blood. So the result of this transfer is a cholesterol-depleted HDL, which is rapidly cleared from the blood, resulting in low HDL. And another atypical transfer is that triglycerides from the VLDL are transferred to the LDL. And again, this is an unusual transfer that takes place because there are a high level of VLDL present. And so this triglyceride-enriched LDL is acted on by an enzyme called hepatic lipase in the liver, and it removes the triglycerides from the particle, and this results in another particle. It's called small dense LDL, small dense LDL, which circulates in the blood, and this small dense LDL is what is going to increase risk of cardiovascular disease. Because it's so small, it can easily penetrate the arteries and begin the process of atherosclerosis. So as a result of obesity, we see blood lipids follow a pattern that's called the lipid triad. So this is high VLDL, low HDL, and high small dense LDL. And it's a pattern associated with an increased risk of cardiovascular disease. And if you know anyone or have had blood work done, you might have seen the LDL or the HDL, or if you have family members, you might have seen it on their blood test results. So these might, or I guess you had a lecture on it too, but yeah. So looking at the link between obesity and cancer, we see in this table here there are a number of cancers that have been shown in cohort studies to have an elevated risk in the presence of obesity. So the two cancers most directly linked to obesity are colon cancer and postmenopausal breast cancer. One common cancer that is missing from this list is prostate cancer, because the scientific literature is somewhat confusing for this cancer, in that although body weight may play a role in the development of prostate cancer, it may not, perhaps it may not have a role in the development of prostate cancer. It may have a role in its progression. So this slide shows how cancer develops. And cancer is a disease that is characterized by a series of genetic mutations that occur in a cell. So these mutations result in the cell differentiating, meaning that a colon cancer cell will no longer function as a colon cancer cell. So instead, the cell will proliferate or grow very rapidly and uncontrollably, and it will not respond to natural stop signals that healthy cells will have to control the growth. Sorry, I'm just having a bit of trouble with my computer here. Howard, can I get you to come down? I just have, the mouse isn't working. Yeah, sorry. So we were talking about how with these cancer cells, they won't respond to the natural stop signals that healthy cells usually have to control growth. So that means it cannot repair its mutated DNA, which is the way healthy cells function, and they become resistant to apoptosis or programmed cell death, which is a method that the body uses to get rid of the cells that it cannot repair. So in the figure shown here, you see that the colon tissue cancer can begin with a single mutated cell, and this cell grows into a tumor that will remain contained within the colon. And if it's left undetected, the tumor can metastasize, meaning that the cancer cells break and or break through the membrane of the epithelial tissue and are released into the bloodstream. So the majority of these cancer cells, they usually do die on their own into the bloodstream, but only a few survive, and they do lodge into other tissues like the lungs, the bone, or the brain, and the cancer becomes much more difficult to treat, and it may not always result in a good prognosis for the patient. So the way that obesity and cancer are linked are through two hormones, insulin and estrogen. So these hormones both stimulate the growth of cells, which are not necessarily a problem if you're dealing with healthy cells, but if one of the cells happen to be a mutated cell, then these hormones can promote tumor development. So insulin specifically stimulates the growth of cells and suppresses apoptosis, which you recall is the process by which the body eliminates damaged cells. And free estrogen stimulates the growth of breast tissue, and in postmenopausal women, it has been linked to the promotion of breast tumors. So estrogen circulates in the blood in two forms. One form is bound to a protein called the sex hormone binding globulin, and in this form, estrogen is less bioavailable, and that is less able to actually stimulate cell growth. Estrogen can also appear in the blood in free form, where it's more bioavailable and more able to actually stimulate cell growth. So with this in mind, this figure shows how obesity can stimulate tumor growth, especially colon and breast tumors. So obesity increases the release of free fatty acids into the blood, which promotes insulin resistance and hyperinsulinemia by pathways that we've already discussed. So this increased level of insulin acts on the liver to reduce levels of the sex hormone binding globulin, and this increases the levels of free estrogen in the blood. So the increased levels of adipose tissue and also increased free estrogen in the blood, a synthesis of estrogen occurs in this tissue. So by the two pathways, the levels of free estrogen rise in the blood, and this estrogen can stimulate the proliferation of breast cells and suppress their apoptosis, resulting in tumor development. So high levels of insulin can also directly act on colon cells, again stimulating their proliferation and suppressing apoptosis, resulting in tumor development. So in addition to the metabolic effects, there are also psychological and social consequences of obesity. I'm not sure if anyone has heard of the term weight stigmatization or fat shaming. It's unfortunately something that happens to people who are in larger bodies, and it refers to negative attitudes, mistreatment, and discrimination based on weight status, and particularly negative attitudes towards people who are obese. And of course, it's very damaging, especially to children. And this is an attitude that, or awareness that we can all have when planning to enter health-related fields, and being mindful of your own biases and how you show up when you're talking to other people. So, does anyone know what percentage of people who attempt to lose weight, what percent fails? Yeah. Yeah, 90%, as you said. You said what? Oh, okay. Yeah, and people often feel like just because someone is not able to lose weight, or because they're not able to really follow through, that there's a lot of blame on the individual themselves. But as I'll talk a bit more, often the factors that affect someone's weight, yes, there are some things that are within their control, like diet and exercise, but there are many other factors that can affect someone's weight, including the physical environment and even weight stigmatization, how that affects someone's mental health. So it is something that's really important to keep in mind, beyond all of the physical impacts that having obesity can cause. So, the unfairness of weight stigmatization is evident by the 90% of people who attempt weight loss but gain it back. And as I was saying, we live in an environment where people are generally gaining weight, and sometimes they are making a conscious effort to actually manage their body weight, but people often may make judgments or assume otherwise. And it sounds like you'll be talking about the environment more, or the obesogenic environment, in the next module, and talk about why weight loss can be so challenging. Yeah, so just to highlight some non-dietary factors from a public health perspective, we know that, again, weight stigma places responsibility of someone's health or their weight on the individual, but there are many other contributors of obesity risk, including age, sex, certain ethnicities. There's also the matter of socioeconomic factors or sociocultural factors like income and education. I'm not sure if many of you have heard of this term called food security or food insecurity, which is when someone has difficulties with accessing food, because one reason can be because of limited income or difficulties accessing culturally appropriate food. And as we know, although many nutritious foods, especially fresh produce, it can be more costly, and a lot of ultra-processed foods can be cheaper, and so that's why people who have a limited income or who experience food insecurity may be at a higher risk for developing these health issues. And yeah, we talked about the environment. Other factors that can affect someone's weight includes medications as well, and chronic stress. We know that there are some side effects of certain mental health medications that can lead to weight gain, inadequate sleep. So there are many other factors that may not necessarily be within an individual's control when it comes to weight. So again, just to reiterate here, you can see a regain of body weight going up to 60% or even higher after someone attempts to lose weight. And there are many other factors that may affect the regain of weight. Often what we also see is in patients is that people will try some pretty extreme diets or try to eat in a way that isn't necessarily going to be something that they can follow in the long run. Many people try to lose weight very quickly, and find it hard to follow if their diet is very restrictive. And so, again, there's so many reasons, there's so many layers to these issues around weight. So, I mean, I hope you still listen, but you won't be evaluated on this because I just wanted to include this just for interest. But one technique that we may use with patients is a technique in nutrition counseling called motivational interviewing. So this is a counseling strategy that health professionals use. So physicians use it, dietitians use it to help support behavior change, including dietary changes. So it's a way of talking and working with someone that helps to increase their motivation to change and work through ambivalence. So often, you might feel this way too. Other people that you know in your life who are trying to make diet changes, often we know what we need to do. Like, I need to eat less sugar, or I need to have more vegetables. People often have the knowledge, but what's difficult about diet change is to actually put it into practice. And again, it's not because someone doesn't have, enough, doesn't have the stamina, or because they're lazy. It's because people are busy, they're used to eating a certain way. Cost, again, is a factor. And so making diet changes can actually be very difficult. And so using this counseling approach to help support clients in enhancing their motivation, finding out what their priorities are, how to address barriers to change, helping them to feel more confident, can be a useful technique, especially when working with people who are trying to lose weight. So there is a difference in what we would call nutrition education, where we talk to someone and provide education or information about nutritious foods, and a difference in how we talk to someone when we are counseling. It's not the same as like mental health counseling, but some of the core approaches or concepts may overlap. So I don't know if anyone wants to share, but any thoughts on why nutrition counseling may lead to more meaningful behavior change than just telling someone to eat less sugar? Yeah. Yeah, that's a really good the work, the effort it takes, and the time it takes to make those changes, especially if someone, as you said, is trying to track what they're eating. It's on top of all the other things we have to do in our life, it can feel like a lot. And so for people who do have the chance to work with a dietitian on an ongoing basis, this type of approach can be valuable. So this is an interesting model that we use when applying this counseling strategies. It's called the trans-theoretical model of health behavior change. And you may relate to each of these stages, but it basically explains each of the stages that someone goes through when they're trying to change anything, especially something related to their health. I believe this model was first used in addictions, or I think in smoking, but it can be applied to diet changes as well. So often where many or some people start in this pre-contemplation stage, where basically it means that it's someone, for example, if they're trying to reduce their sugar intake, they're uncertain. You might all know someone who maybe knows that they might need to reduce their sugar intake but doesn't want to or isn't ready. And so that's where someone might be, like their headspace might be, if they're pre-contemplating. Contemplation, when someone moves into that stage, some characteristics may include that they are starting to realize that they do need to change. Like maybe they should have, one less can of per week, or that they need to reduce their sugar intake. So they're starting to realize that they need to make this change, but they may not be there yet. And so as dietitians, we will try to increase someone's confidence or talk about some barriers to these changes to help them feel more like they're ready to make those changes. And then when someone moves into preparation, they've committed and decided that this is something that they do want to change. And that's when we try to help someone develop some goals and a plan to help stick with the change. So, for example, with this sugar one that I've been talking about, perhaps someone is drinking a can of every day. And so in their action plan or their goal, we might talk about maybe reducing their can of pop to like 2 or 3 times a week. So finding a goal that's realistic for the patient. And then there's the action phase, when someone actually follows through and does follows their goal. And then maintenance, when someone's able to continue to stick with it. And then relapse is part of the process as well. It's very normal, say I've committed to having two cans of pop per week instead of every day, but maybe I had a bad day and I really wanted to have one like every day that week because it was really stressful. So that's an example of relapse, and it's very normal, and we want to be able to support patients and clients through that phase so that they don't feel judged or shamed by it, that it's part of the process of change. And so this can be applied for people who are wanting to manage their weight and other changes related to health, like even physical activity. So a lot of applications in practice. So yeah, that concludes section 3. I hope you were, even though you weren't being evaluated on it, still found that last part interesting related to health behavior change. And it looks like you have some self-assessment questions in the next section that follow in this module. And as I mentioned yesterday, if you are able to provide any feedback, that would be really helpful. So I'd really appreciate if you do, and thanks for having me.
Hi everyone, I just have a couple announcements. So if I can have your time for 5 minutes. Hello? Okay, well, I'll just say the announcements anyway. So I'm Howard, I'm the senior TA for this course, and I've been getting a lot of repetitive questions, so I thought I'll just answer some FAQs live. First of all, for assignment 1 regrades, if you email me about regrade, and if something small, like for example, the TA forgot to put in a grade for one of the criteria, I have replied and fixed those on Quirkus already. But if it's a formal regrade request, please just look out for an announcement from Dr. Lar in terms of how to proceed. I need her to tell me if I should host office hours or take email requests to regrade. So just in the coming days, there should be an announcement in terms of what procedure to follow, and I'm happy to do those regrade requests. FAQ 2, for assignment 2, there is indeed 2 Dropbox on Quirkus. Those are just so that we can have a placeholder to put your marks into the system. Otherwise, it comes up as missing. So if you have made submissions already, thank you so much. But if you have not, sometime today, just make a submission so that the TA can put in your grades and it won't be an automatic 0. Just your link, the title, the link is fine. And then don't worry about the link indication. We will cross-check that with Critic. Third thing, if you email me about reweighting your midterm to your final or reweighting your assignment 2, I would have replied already in terms of acknowledging I got your documents, or reply that you need to share your documents, and I have always CC Dr. Lar. That being said, if Dr. Lar does not reply to the email thread, that means I have also not have heard back. So if you send me an email every other day asking if she saw the email, if you don't get a reply, I don't get a reply. So just a heads up. And lastly, the TAs don't design the final examination. So if you ask us what to study for and to how much detail, it should be. The volume is okay. Well, come talk to me afterwards. But basically, the TAs don't design the final examination, so if we cannot tell you what exactly to study for and to what detail. Okay, so those things, please talk to Dr. Lar, because the TAs have been getting me questions on that, and we don't know what to do. Okay, thanks, and have a great weekend.